Please note, the opinions expressed in this podcast are those of the individual speakers and do not necessarily reflect the views of Tri-County Orthopedics. Any medical advice or treatment recommendations discussed should always be reviewed with your own healthcare provider. This podcast is not a substitute for professional medical advice, diagnosis, or treatment.
Welcome back to the podcast. Today we are excited to have Dr. Klein back for his second episode. First episode we recorded was all about broken bones. So if you haven't listened to that, go listen to that episode. Today we are going to be talking all things reverse shoulder replacement. So welcome back, Dr. Klein.
Thank you for having me.
To start, where did you learn how to do shoulder replacements, and then what made you start doing more of them?
So in my residency, we did do a handful of shoulder replacements. We did a lot of shoulder fracture work, and we did a lot of shoulder arthroscopy work where we were repairing rotator cuffs and things along those lines, but we didn't do tons of shoulder replacements. And when I came here, Dr. Montgomery asked me if I wanted to learn how to do shoulder replacements and start doing a little bit more of the hospital-based practice. And I was somewhat interested in learning shoulder replacements. I'd done a few of them. I didn't really know what to expect, but I spent some time with him in the OR. He taught me how to do shoulder replacements, the way he does them, and I've actually been very not only pleased but surprised with how well patients can do. Patients have been saying the same thing, which is what I wanted to bring up also about recovery, how much easier it's become. Even in the past 10 years, things have changed dramatically.
And we'll get into recovery later on in the episode. To start, why don't we talk about just really simple, the difference between a reverse shoulder replacement and a standard shoulder replacement?
The reason why I wanted to do reverse shoulder replacements first is this kind of talk is going to apply to more patients. So traditionally, an anatomical shoulder replacement really does one thing. It replaces the surfaces of the joint. So you have, instead of bone rubbing on bone, you have metal gliding on plastic, and you have a smooth motion. You can restore function. And that's really the same theory that you get with hip and knee replacement. You can make some adjustments to the bone to restore alignment, but primarily what you're doing is putting in a new surface so that things can move smoothly. Now, where the shoulder differs from the hip and the knee is that one of the primary drivers of arthritis and one of the primary reasons the shoulder fails over time is the rotator cuff fails, the shoulder becomes a little bit unstable, and that micro instability causes the joint to wear itself out. So now you're left with two problems to address. Instead of just resurfacing like a hip or a knee, you also have to address rotator cuff dysfunction. So in the old days, there were some specialized regular replacements, so to speak, where you couldn't really restore tons of motion, but you could decrease pain. The magic, really, of a reverse shoulder replacement is that it allows you to rearrange the joint in a way where the rotator cuff becomes unnecessary. And now you have a shoulder that has a new surface. You've rearranged the joint where the rotator cuff is not necessary, forces the deltoid muscle, which is the large muscle on the side of the shoulder. It forces it to do more work to be able to elevate the arm, and you have a shoulder that can now work even without a rotator cuff after having bad arthritis. So it addresses the global reason why a lot of shoulders develop arthritis.
So shoulder replacement, you're just repairing the surface. Reverse, you're moving around the rotator cuff as well as resurfacing.
So a great question, because that's where a lot of patients are trying to understand what the reverse replacement is. Now, there's actually a great quote from Grammont. He was the French surgeon in the 1980s who really developed the reverse replacement. And his quote came out to basically saying, patient doesn't really care what you do inside their shoulder. Just make it work and make it not have pain. And that's really true. I still like it when patients understand what's going to happen to them, because a lot of patients come in and say, you're going to reverse, what are you going to do? Like, what are you doing here? Mm-hmm. And I think it really helps when people understand that the rotator cuff is not repairable. When you have a shoulder that's got really bad arthritis and a really old cuff tear where the muscle is atrophied, you can't repair the cuff. You can resurface the joint, and then what you do is you change the center of rotation. What you're doing is you're moving where the ball and the socket are, which allows the deltoid muscle to now have more leverage. And because of that, the deltoid muscle can be used to lift the arm. So you're not repairing the cuff because you can't. You could think of this as like you're kind of hacking the shoulder because it's not anatomic. And I'll tell people that also, especially if a patient's really thin, they may notice the change in contour of their shoulder. And I'll tell them beforehand, this is somewhat of a life hack in your shoulder. We're rearranging things. We're going to take advantage of a muscle that's still there in order to force it to do things that it wasn't doing before. You're changing it a lot. You're moving the center of rotation. Now, you could theoretically leave the ball and socket in place and change the center of rotation using the implants, by keeping a socket in the socket and a ball on a ball. In the 1970s, the early designs that were meant to restore function after rotator cuff tears, and the condition that happens when the rotator cuff fails and leads to arthritis, we call that cuff tear arthropathy, meaning the joint has worn out because the cuff has worn out. So there were designs in the 1970s by Dr. Neer which were meant to change the center of rotation, but the reason those designs never really took off is the shoulder blade where the socket is attached really doesn't have a lot of real estate. So it's much easier to attach a ball and change the position of the ball on the shoulder blade than to put a new socket on the shoulder blade and change the position that way. It's somewhat of a technical thing where you're working within the constraints of the amount of bone that you have to work with.
What is the primary medical condition that is leading to a reverse shoulder replacement? Is it rotator cuff tear, fracture, failed previous surgeries?
The number one reason people will have a reverse replacement is really cuff tear arthropathy. It's much more common than the other reasons, but the other reasons are becoming somewhat more common. We treat a lot of fractures with reverse replacements because there are many fractures, especially in the older population, where people are somewhat older and the bone quality is not great. The rotator cuff also may be starting to wear out, but they're healthy and they want to maintain an active lifestyle. If a patient has a fracture that is just non-repairable, and there are some that break into so many pieces that you can't fix it, you can make the shoulder function really, really well with a reverse replacement. You don't need the rotator cuff to heal. If it does heal, patients will do better, but you can still get a very well-functioning shoulder without a good rotator cuff.
And what are the demographics? Mostly older adults?
The other thing, before getting to that, you mentioned failed surgeries. There are times where either a failed anatomic replacement or a fracture that was repaired that didn't go on to heal will require a reverse replacement. Primary reason for anatomic failures is people either putting an anatomic shoulder into somebody who doesn't have a good cuff, so patients don't really restore function. Those patients will we can switch them to a reverse replacement to restore function. And then similar to the way a dysfunctional rotator cuff can cause a well-working shoulder to wear out, a fracture that was repaired and then didn't go on to heal can also cause the joint surfaces to wear out. So we revise those people to a reverse replacement.
So there can kind of be a lot of different things that lead to.
There are many things. The reverse replacement you could think of also as the last stop in the road. This is the last surgery that can be done that can restore function, but the best part of it is there are some salvage surgeries, meaning the last surgery that's like the Hail Mary that you're hoping it's going to work. This is not really like that. It's the last possible surgery that you can do, but it works well. So patients really can restore function from all of these different problems. Function can really be restored well.
And so demographics, is it usually older
Yeah, so
people?
demographics. So to compare demographics of shoulder replacement to hip and knee replacement, shoulder replacement patients tend to be a little bit older, where we believe with hip and knee replacement, people wear out their hips and knees sooner because we walk on our legs, not on our hands. And because of that, people who have shoulder arthritis tend to tolerate it better for longer. So average age of hip and knee replacement is somewhere between 60 and 75. Average age of shoulder replacements is more somewhere between 65 and 85.
So when a patient shows up to your office, what are the symptoms that they're presenting with that then lead you to decide reverse shoulder replacement?
So number one reason people come to the office is just pain, and that's something that's really like nationwide. Number one reason you go to your doctor, pain, something's hurting, you go to your doctor. The thing that will lead me to tell a patient that they are going to need a shoulder replacement, especially on the first visit, I really try to not talk about surgery on the first visit unless the patient comes in and says, this has been killing me for years, it's something that I've been trying to deal with. Really try to do conservative stuff first. You can do physical therapy and cortisone injections and anti-inflammatories, and because we don't walk on our hands, people tolerate that pretty well. And not everybody with arthritis will end up having a replacement. But with that said, an x-ray finding of advanced arthritis or a physical finding of significant loss of motion. A lot of people who have cuff tear arthropathy or even regular arthritis really can't lift their arm over their head. My uncle, who's 69, he's turning 70 on Sunday. Every time I see him by a family thing, I'm always like, so Donald, when are we doing your shoulder replacement? Because he reaches out to shake my hand hand by shrugging his shoulder. I looked at him once. I'm like, Donald, what's up with your shoulder? He's like, how can you tell? I'm like, what do you mean, how can I tell? You can't lift your arm. You're reaching out in front of you by shrugging your shoulder. You can't lift your arm like up to reach your own head. And that's a real big improvement that people can get with replacements, where before replacement, a lot of patients can only bring their arm up to about 90 degrees. And then afterwards, range of motion really improves a lot.
So back to conservative treatments, that's going to be physical therapy, cortisone injections.
For patients who are either, they can fall into one of three camps. Either they're young and they don't want to consider surgery, either too old and they don't want to consider surgery, or they're not in tons of pain and they can really benefit from getting some stretching with physical therapy, some anti-inflammatories and cortisone to decrease their pain. So at the first visit, I'll offer an anti-inflammatory, whether that's over-the-counter or prescription based on patient's preferences, a trial of physical therapy, and I'll offer a cortisone injection also. Not everybody wants to go aggressive treatment on their first visit, so people will wait for that cortisone injection for the second visit, but it tends to be quite helpful.
So let's move into surgery. In very simple language for us, can you walk us through what happens during the surgery?
Sure. I'll give you my spiel that I'll tell patients, because that's what happens after you sit a patient down. You tell them, look, a replacement is really the best option for you moving forward. You're young, you're healthy, you've got bad arthritis, and you know you're going to need it. So not that there's a rush to do it, but you've got many years ahead of you, and this is really the best way to treat this. So then the patient will lead to saying, well, so what's that like? Walk me through that. So sure. So a shoulder replacement procedure takes about an hour. It's done under general anesthesia, so patient will sleep through it. And we also have the anesthesiologist give a nerve block injection for the shoulder. And the nerve block injection is really the thing that has changed the game, because that can keep a shoulder numb for about 3 days, where once the nerve block wears off, the majority of the surgical pain has already passed. So many patients are telling me that they come back to the office a week after surgery and they say, I was expecting all this pain afterward and it never really showed up because the nerve block kept them numb during the first critical 3 days when there would have been severe pain.
Right.
So surgery is usually done as an outpatient. There's no need to sleep over. Patient will go home the same day wearing a sling. And while that sling is on for the first 2 weeks after surgery, patient can use their hand. So I don't mind if people will use their cell phone. I don't mind if people will feed themselves with a fork and a knife or button their buttons. I just don't want them lifting the arm away from the body. So the sling is there really just to keep the arm close to the body. And 2 weeks after surgery, patient's allowed to remove the sling and begin physical therapy. And the recovery process, you could really split up into 2 different stages. You have stage 1, where you go from having surgery and your arm isn't working well till about 6 weeks after surgery. By 6 weeks, you're using your arm for your daily activities. You're dressing yourself, you're feeding yourself, you're able to touch your hair and lift your arm to reach your head. And that's the first 6 weeks. So 6-week recovery time frame till you're generally back to your life. And then until strength is restored, range of motion is maximized, and you're starting to really put it behind you, that takes about 3 to 4 months. So there's 2 stages to recovery, roughly 6 weeks while you're early recovering till you're back to your life, and then a total of 3-4 months till you're really restored your function.
Okay. So technically speaking, what's happening in surgery, in the operating room?
So a patient will come into the operating room and they're seated on what's called a beach chair table. It's a seated position. They're semi-upright. And they'll get the general anesthesia. And then after the skin is thoroughly sterilized and the drapes are on, we make an incision across the front of the shoulder. It's about 10 centimeters in length. We elevate and lift the deltoid muscle out of the way. The rotator cuff muscle in the front gets lifted off. We then remove the old joint surface, meaning the old ball and the old socket get removed. A new ball gets screwed in where the old socket was, and then a new socket gets implanted where the old ball was put in place. We have trial implants that we put in to make sure things fit nicely. We check range of motion and stability before closing, and then the rotator cuff muscle gets reattached and the deltoid muscle gets closed up, and then the skin gets closed.
Okay. So let's move into recovery. How soon until patients can start physical therapy?
I wait 2 weeks before patients start therapy, and that's number one. In the first few days, there's not much to gain with physical therapy, and also the rotator cuff muscle has to be lifted in order to get inside the shoulder. So we have to repair it once we're done, and we want that repair to hold. So I wait 2 weeks before starting anything.
Okay. And then when can they get back to things like work,
Sports.
driving, sports, normal activities?
Sure. So driving takes about 4 weeks. You have to be, number one, out of the sling, and then also have control of the arm. So getting back to work is also dependent on driving for a lot of people. So if you work from home and you type, you can be back to work by about 2 weeks after surgery. If you have to drive to work and you you have somewhat of a sedentary type of work in an office, take about a month off. But then getting back to sports, like getting back to something where you have real overhead motion like tennis, that'll take about 4 months because you have to, number one, restore motion. So you have to stretch with physical therapy till your arm can go high enough. And then you also have to restore strength. So simpler sports, even something like pickleball can take a while because you really have to restore range of motion. Golf. So I'll let patients swing a golf club by 6 weeks where they're not making contact, and then full contact by 3 months.
What about something like swimming?
Swimming, also in a pool by 6 weeks, you're not going to be comfortably doing laps till about 3 months.
Okay. Is there any activity or movement that will never fully return?
So specific to reverse replacements, yes. Because of the design of the implants and because of the way we rearrange the shoulder, the reverse replacement loses some range of motion. So I'll tell patients with a regular replacement, you can expect about 95% range of motion. With a reverse replacement, you can expect about 85 to 90% range of motion. And the two specific things that decrease where I would notice it would be in full forward flexion of the arm, where if you lifted your arm straight overhead like to change a light bulb, you can get your arm to go straight up. With a reverse replacement, you could expect to lose about 15 degrees of that end range of motion. And then the other one specifically is in reaching your back. So a normal shoulder, people can reach all the way up to the mid-back, specifically like for fastening a bra. With a reverse replacement, you probably will not be able to get your arm up that high, even after full recovery. But patients, they can still get their pants on, put a belt on, scratch their back. They just won't really be able to reach really high up.
Are you regaining all your strength back?
So, depends what you mean. I say yes. And I also don't really restrict my patients after surgery. With the older implant designs, there were some lifetime restrictions where surgeons would say, don't lift more than 25 pounds, don't do anything real heavy with this. But I have two reasons why I don't tell patients to have restrictions unless I'm doing a really young person. Number one, people who need shoulder replacements like this or reverse replacement, in their age group, they're not really looking to do anything that will overtax their implant. So you can play golf, you can play tennis, you can swim, you can run, you can water ski, you can really do a lot of activity. What I don't like people doing with a shoulder replacement is heavy bench press and push-ups. So bench press over 100 pounds, regular push-ups, because patients will ask this. They're like, what can I not do afterward?
I'm thinking of like a young patient who likes to lift weights.
So young patients for reverse replacement, number one, they're not that common. So there are some restrictions. I'll tell people not to bench press over 100 pounds and not to do regular push-ups anymore. That's really what I personally believe. The older implant designs, the manufacturers would tell people not to lift more than 25 pounds. The newer implants are much, much stronger.
I was going to ask about the durability of the implants.
So we don't have full long-term data on some of the newer implants. I would expect a shoulder replacement nowadays to last somewhere between 20 and 30 years. The part that wears out is the plastic lining. The plastic linings have gotten a lot better over time. And for patients over age 60, I would expect it to last a lifetime because somewhere between 20 and 30 years gets you from 60 to 80 or 90. By that point, patients are putting a lot less stress on their implant, and then it lasts the rest of their life.
Do you ever have any complications with this surgery?
Complications with any surgery happen. The primary complications that everyone should know about before surgery, risk of infection, fracture, or dislocation. Those risks do exist. I would consider those risks to be somewhere just under 1%. So they can happen. That number is real, but it's not common enough where people day-to-day need to worry about it. I think the major complication that happens with shoulder replacements that I see is shoulder soreness. And you don't necessarily consider that a complication or a surgical complication. It's more of a potential outcome that people have to know about. Because a year after surgery, where you've maximized your range of motion, your strength has returned, you're just using your arm without really thinking about it, and if you use your arm a lot, like someone's out in the yard and they're weeding all day, the shoulder can get sore. And the reason for that is because of reverse replacement's mechanics, you're forcing the deltoid, which is that large muscle on the side of the shoulder, you're forcing that one muscle to do a job that 5 muscles used to do.
Right.
So because of that, the shoulder can get sore with repetitive activity. So on the last office visit where I have people after their shoulder replacement, and I'll tell people this before surgery, but I also remind people, in a year from now, your shoulder, God willing, will do very well. If you notice that it's sore after using it all day, take it easy for a couple days.
Right.
And
listen to your body.
yeah, just take it easy, because that'll also help minimize. There are some other complications that are a little more technical. Surprisingly not super rare is if you really overdo it on a shoulder replacement, you can develop stress fractures around it. So I'll tell people, if you start getting sore, take it easy. I don't want you to develop anything further than that.
Okay. So I want to know, how does the recovery for reverse shoulders compare now to how it was, like, say, 10 years ago?
So that's a major thing we talked about, like right at the beginning of this talk, was the recovery process has changed dramatically. Where when I was in residency, I started residency in 2013, shoulder replacement recovery was terrible. It was very painful, and it took a very long time.
That's for shoulder and reverse shoulder.
For both.
For everything.
I actually consider recovery timeline and pain level for reverse or anatomic to be kind of similar. My post-op protocol for both is more or less the same. I don't really change what patients are doing, whether they've had one or the other. But 10 years ago, a shoulder replacement used to be a very painful recovery after surgery. Patients would get a nerve block injection. It would last about 18 hours. Once it wore off, they were in a lot of pain for 2 days, and then they were in their sling and still kind of sore, and it took a while to get over that initial pain.
Yeah.
Now patients come in after having a 3-day nerve block wondering why they're not in pain. Like, why? This really didn't hurt me. I spoke to my neighbor who had it done 10 years ago. They said it was terrible. And why didn't this one hurt? Like, you did a great job. I'm like, I appreciate your compliments. I think I'm doing a good job in surgery, but it's not the surgical technique that's changed that's made the post-op recovery that much better.
Is it mostly the nerve block?
I think so, yeah. I think the best patient story is really the patients, and this is not an individual, but most patients come in like wondering why they're doing so well.
Yeah.
Because they've been told by their friends, neighbors, and physical therapists and primary doctors that recovery after shoulder replacement is going to be horrible. And they're like, you know what? No one told me it would be so easy. And it can be. It's still a major surgery. It still involves physical therapy. There's still all of the normal things that go along with having a major surgery. But people do quite well.
How often are you doing surgeries? In a week, like, say, how many do you do?
In a week, it depends on my week. I have some weeks where I'm in the office more versus in the OR more. But I'm doing, and this is, I think conservatively, I'm doing about 40 reverse replacements a year, which doesn't sound like tons, but reverse replacements and shoulder replacements in general are significantly less common than hip and knee replacements.
Right.
I think I'm doing the most in the practice at the moment.
What advice would you give a patient who you can tell when they come they absolutely will need this surgery, but they're just so nervous or hesitant to do it?
So for the most part, patients who really need it are not so hesitant because they're really suffering. They come in a lot of pain, and it's painful all day and all night, and you can't sleep, and you can't dress yourself, and you can't feed yourself, and it's just unpleasant. So it's not that common that someone will come in who really, really needs it and also really doesn't want to do it, because people will come in saying, shoulder replacement, is that what it's going to take? Let's go. But there are people that are hesitant to undergo a surgery like this. I'll go over my spiel for patients. I'll tell them how long it's going to take. I'll tell them how long the recovery is going to take, and that usually puts people at ease also, because a lot of people who come in being afraid of replacements, and whether it's hip, knee, or shoulder or other stuff, they're coming in with a mindset that it's going to take them a year to get back to their life. It's going to be painful every step of the way, and that's really not the case. So I'll tell them what to expect, and even before getting through their fears, that kind of sets them at ease because they've come in with a different perception.
Right.
So telling them what to expect, in my mind, really helps people know what they're going for, and also telling people that it's quite a routine surgery. So it's not the 1950s or 1960s where everything was more dangerous, from surgery to anesthesia to getting in a car. Things have gotten significantly safer over time, and it really is a very routine surgery. When I have an OR day where I'm just doing reverse replacements, it's like one of the easiest days I have.
Yeah.
Because it's, for the most part, it's the same thing every time. It's very reproducible, and patients are happy with with them.
And they do well.
And they do well.
Yeah. So looking to the future, is there any new technology coming that relates?
There's some new stuff with the socket design where even 5 years ago, I was using an older socket design that was a little bit more stabilized, meaning less risk for dislocations, but also because of that added stability, patients would lose some range of motion. So what I've been doing over the past 2 years is using, number one, a newer design that's a little bit less stabilized, but also coupling that with a ball that's a little bit deeper, meaning we were using like a hemisphere. Imagine like cutting a basketball in half. We were using that as the ball. Now we're using a little bit more than half of the basketball. Okay. So we have a little bit more for the socket to move around. And that's actually improved range of motion. I've seen in the past 2 years since I switched to that design, a significant improvement in range of motion. Yeah, the socket and ball design is what's on the horizon. As far as other stuff, and this may be a little bit of a more technical thing of trying to not need to do reverse replacements, meaning we're doing them because you've got the two problems. You've got rotator cuff dysfunction and you've got a worn out ball and socket. What if you can restore the rotator cuff some way and because of that end up with a regular shoulder replacement? And that's something that's still not really getting off the ground. There's been multiple different things that have been tried and none of them really have been able to do it in a way that's easy to reproduce and is expected to be successful.
Right. Because you said it's not always the arthritis, it's sometimes just the dysfunction of the muscle that leads to needing the replacement, right?
Exactly, yeah.
Is this being done with robotics?
Almost. So the robotic stuff we use for knee replacements is currently in development to use the same robot to do shoulder replacements. It's something that I'm eager to try, but it's not on the market yet. The reason for that is the shoulder is somewhat deeper and a little bit harder for the robot to find bony landmarks to be able to work off of. I'm excited to try a robot, but same way it is for knee replacements. Like you could ask my partners like John Dundon and Aaron Forbes who use the robot for knee replacements, do they need it? No, they don't need a robot. It's a fun toy to use. It makes things a little bit more reproducible for specific things, and it's something that Dr. Dundon's actually working a lot on, using the robot to harvest data on range of motion and patient function and recovery and outcomes. And that's really where the robot's going to be useful, because I don't really see a place where the robot's going to make outcomes better. It's data. Yeah, it's the same way like ChatGPT is harvesting data from the internet to give you answers. So robots hopefully will harvest data from shoulder replacements and give us answers to maybe, I think what a robot might do is create a way to map out a reverse replacement that'll have the same range of motion as a anatomic replacement. Because right now they don't. Right. They come close, but they're not. They're not exactly the same. And if the robot can give us a way to map a reverse to make it function quote unquote normally, that would be great. I can end on saying that shoulder replacements continue to surprise me and my patients regularly because they come in for their post-op visit. Usually people come in at 10 days. They're surprisingly not in pain. And even though I've seen this over and over, still after coming in with a big surgery, and I know because I was there, for someone to say that it was not painful at all surprises me every time. And then the function and the range of motion and really the patient satisfaction it's a pleasant surprise every time someone comes in because it's such a big surgery that people are scared of and outcomes are really, really good.
That's amazing.
Yeah.
Well, thank you for coming back on the podcast and doing this episode.
Thank you. I'm looking forward to doing another one.
Yeah, and we'll see you next time.
All right. Thanks.
If you enjoyed today's episode, be sure to subscribe so you never miss an update. Don't forget to share the podcast with others who might find it helpful, and follow us on Facebook and Instagram at Tri-County Orthopedics to stay connected. Thanks again for tuning in, and we'll catch you next time.